Okay, I think we may start our forum, Professor. Yeah, good morning, good afternoon, and good evening to all. This is our I think this the third ACNS Haneda Microvascular Decompression Forum, and this time we are hosting together with 𝒂𝒏𝒂𝒂𝒂𝒂, and today chairing today's session is Professor Yoko Kato from Fujita Head University Bantane Hospital, Japan, together with Professor 𝒔𝒑𝒂𝒂, who is Secretary of the 𝒂𝒏𝒂𝒂𝒂𝒂 Association of Neurosurgeon, and also working in Republican Specialized Scientific and Practical Center of Neurosurgery, 𝒂𝒏𝒂𝒂𝒂. And today's our speaker is again not other than Professor Fuminari Komatsu, who is an associate professor from the Department of Neurosurgery, Fujita Head University Bantane Hospital, Nagoya, who will speak to us on endoscopic microvascular decompression and new trend in endoscopic keyhole surgery, followed by Dr. 𝒔𝒑𝒂𝒂𝒂𝒂𝒂𝒂𝒂, who is a neurosurgeon from the Republican Specialized Scientific Practical Medical Center of Neurosurgery of 𝒂𝒏𝒂𝒂𝒂, who will speak to us on our Republican Center experience in MVD for trigeminal neuralgia and hemifacial spasm. We are glad to have Professor Gleb Danilov as our discussant for today. He's the head laboratory of Biomedic Informatics and Artificial Intelligence, R&D Budenko Neurosurgical Center from Moscow, Russia. Before we start with our speaker, may I call upon Professor Kato and Professor 𝒔𝒑𝒂𝒂 to give us a short message. Professor?
Please unmute your mic, Prof.
Hi, everybody.
Please go ahead.
My name is 𝒔𝒑𝒂𝒂𝒂𝒂𝒂𝒂. I'm very grateful that we are gathered here in an online session in this special series of microvascular decompression and neuralgic cases forum. So I greet Professor Yoko Kato and Professor Fuminari Komatsu Sensei. We are very grateful for this wonderful collaboration between our centers, and special thanks to Asian Congress of Neurosurgeons for this tireless effort putting in education of young neurosurgeons, and not only young neurosurgeons, for the neurosurgeons of all over the world. And thank you so much for joining this session. And thank you so much, Professor Yoko Kato.
Thank you very much, 𝒔𝒑𝒂𝒂𝒂𝒂𝒂. So long time no see, but you look very fine. I'm so happy. So today the Komatsu Sensei and also another 𝒔𝒑𝒂𝒂𝒂𝒂. Very much expecting the lectures. I think MVD is very popular disease. So many neurosurgeons is trying to cure the diseases. So that's why we need more knowledge from them. So I think let's start.
Thank you, Professor. Let's call upon Professor Komatsu to deliver his lecture. Professor.
Oh, thank you, Dr. Liu. Can I share my screen?
Yes.
Can you see that?
Yes, Professor. Can have a full screen.
All right.
Thank you.
Right. Thank you for giving this opportunity. I'm Dr. Komatsu from Fujita Health University Bantane Hospital, now in Japan. Today's my topic is endoscopic microvascular decompression for trigeminal neuralgia and hemifacial spasm, a new trend of endoscopic surgery. So the Nagoya is almost located at the center of Japan. This is our team. We are working under Professor Yoko Kato. Personally, I ran the endoscopic anatomy in Vienna around 2010 for minimally invasive endoscopic keyhole surgery. This is my basic knowledge of my work. And also I have some clinical experience in India, approximately 2 years. This was a very good opportunity for me to have a lot of the clinical endoscopic surgery. Today my topic is MVD, and for MVD, the identification of neurovascular conflict and appropriate decompression is especially important. The endoscope provides a panoramic view even in the deep surgical field with minimally invasiveness. Transposition technique is a desirable method for long-time outcome. So this is our method of the endoscopic MVD. The patient is placed in the park bench position. The less than 4 centimeter skin incision is made. And then the 1.5 centimeter red sigmoid keyhole is created. The endoscope is fixed on the pneumatic endoscope holder, and single shaft instruments are mainly used for the procedures. The 4K ICG endoscope system is used for our operation. This is the instrument, the dissector, scissors, and alligator forceps. These are all the single shaft instruments. And as you know, the decompression method is classified in 2 methods, interposition and transposition. And it is reported that transposition gives us a good long-term outcome. That's why we do the transposition technique, and under the endoscope, using only fibrin glue is easy and simple and suitable for the endoscopic surgery. So we do the transposition with only fibrin glue. I showed some illustrative cases. First case is trigeminal neuralgia, left side. SCA is offending artery on 3D image. The video is shown. After making a skin incision, this is keyhole, and then 0-degree endoscope is inserted. Now we can see the trigeminal nerve, and SCA is compressing the root entry zone of the trigeminal nerve. So the arachnoid around the trigeminal nerve is bluntly dissected, and the offending artery is also dissected from the nerve. And then this offending artery is simply fixed with fibrin glue on the tentorium. Secure fixation is confirmed, and also the trigeminal nerve is separated from the vein. This is the final view. Pre and post-surgical views are shown. The compression was clearly, obviously achieved. This is a case that petrosal vein is well developed and restricted the visualization of the trigeminal nerve. Even such case, endoscope can see the offending artery and surrounding structure. ICG is given, and then again the offending artery is separated from the trigeminal nerve and attached on the dura. Even from the small space, we can see the trigeminal nerve is decompressed completely, and also some surrounding structures are clearly seen. The next case is the trigeminal neuralgia. Offending artery is the trigeminal cerebral artery. Trigeminal cerebral artery is the variant artery from the basilar artery. The video is also shown. This is trigeminal nerve. We can see the trigeminal cerebral artery penetrate the trigeminal nerve, and also the it compressed the trigeminal nerve. So initially the SCA is separated from the nerve. It's fixed on the tentorium, and also the trigeminal cerebral artery is mobilized and attached on the dura. But complete decompression was not achieved, so interposition was also added. And the distal part of the trigeminal cerebral artery is also separated from the nerve and attached on the tentorium. This is the final view. Decompression was achieved beautifully. These are pre and post-surgical views. Such TCA cases are 3.4% in our series. And then the next is the hemifacial spasm. This case is the 𝒂 is offending artery. Also, video is shown. Skin incision. Skin incision is almost same as trigeminal neuralgia. And keyhole is made. And then endoscope is inserted. We can see 7-8 nerve complex and the 9 cranial nerve. So the 30-degree endoscope inserted, and the 𝒂 is running on the facial nerve. So this offending artery is separated from the facial nerve and attached on the dura. Now we can see the indentation on the facial nerve clearly. And also the perforator from the 𝒂 are well preserved. Finally, ICG is given. Again, the pre and post surgical views are shown. The excellent decompression was achieved. Next case is the hemifacial spasm left side. The 𝒂-𝒑 common trunk is the offending artery. The video is shown. Keyhole is made. And then again, we can see the 7, 8, and 9 cranial nerves. 𝒂 and the 𝒑, these are running on the facial nerve. Still, we cannot see the facial nerve. But after lifting the 𝒂, we can see the facial nerve partially. So 𝒂 is mobilized and attached on the dura, little by little. So now we can see the facial nerve, and also this bifurcation of the common trunk is also attached on the dura. And finally, the pica branch is attached on the dura in the same manner. This is the final view. We can see the indentation on the facial nerve so clearly. Also, the many perforators from the offending arteries are well preserved. These are pre and post surgical views. And the next case is a hemifacial spasm. Vertebral artery is offending artery in this case. Again, video is shown. Incision is same. Keyhole. And then we can see the 7, 8, and 9 cranial nerves again. The under 30-degree endoscope, the vertebral artery is running on the facial nerve. This vertebral artery is lifted and attached on the dura, and the fibrin groove is applied enough, and then decompression of the facial nerve is well achieved. We can see the indentation on the facial nerve. These are pre and post surgical views. This is also the hem facial spasm associated to the vertebral artery. But during operation, we found that the ICA is attached on the subarcate fossa and the surrounding dura. These are also variant of the ICA. This ICA is separated partially from the dura. Some space was created, 30-degree endoscope inserted, offending artery, a vertebral artery is observed. So in the same manner, vertebral artery is lifted. The pica arise from the vertebral artery is also observed. And these are fixed with fibrin glue. And decompression was confirmed under the 30-degree endoscope. And finally, this variant ICA is confirmed with ICG angiography. This kind of the adhesion ICA is also observed in 3.3%. These are a very rare case. So far, we had more than 550 endoscopic MVD cases in last 4 years. These are surgical results in last year. Last year, we had more than 200 cases. And for classical trigeminal neuralgia, approximately 94% patient is well recovered. As for hem facial spasm, more than 90% patient symptom disappeared. And regarding complication, the hearing impairment, sensory hearing impairment was observed in 0.5%. CSF leakage requiring the repair surgery was 0%. And wound infection requiring debridement was 0.5%. The complications were very few. For discussion, the MVD for endoscopy, under endoscopy or microscopy. Some literature said the endoscopy has some advantage, and surgical result is better in endoscopic surgery. But on the other hand, endoscope and the microscope, these are surgical results are same. Such articles are also reported. From different viewpoint, Dr. Lee reported that regarding the surgical result, no significant difference was observed, but less post-operative headache is observed in endoscopic series, meaning that less invasive surgery in endoscopic cases. So in my opinion, it's still controversial to conclude the significantly better surgical outcome in the endoscopic group. However, the endoscopy has significant difference regarding minimally invasiveness. This is my conclusion. Thank you for your attention. We will welcome the patient to Haneda Clinic in Tokyo, Japan. Thank you. Thank you very much.
Thank you, Professor Komatsu. Now I hand over the session to Professor 𝒔𝒑𝒏 for the discussion. Professor.
Thank you so much, Komatsu Sensei. That was very excellent presentation with excellent results. Endoscopic microvascular decompressions, indeed, very useful technique in this microvascular decompression of both trigeminal and other cases. My question is, did you have any cases where, in case of transpositioning of the big arteries like vertebral artery or basilar artery, when you transpositioned the artery and you have it with fibrin glue, were there any cases of detachment of vessel from the tentorium or the attachment point? In the follow-up cases, like
in some cases, as you said, that it's very difficult to attach the offending artery on the dura. Such cases during the operation, I think the fixation was impossible. So in that case, I think that not only the fibrin glue, some reinforcement by Teflon felt is made. But it's limited cases and depend on the cases.
Okay, so you decided by the case by case, and if it's a very heavily offending vessel, you would better choose options of interposition and maybe other techniques like sling technique. Or you just...
Yes, you are correct. Yeah, sometimes we have to do the interposition technique in limited cases.
Okay, thank you so much.
Thank you.
Thank you so much.
Professor.
So if any other...
Yeah, Professor Danilov, your comment.
Yeah, thank you so much, Professor Komatsu, for a very beautiful lecture, very beautiful illustrations as usual. I have a aesthetic pleasure watching your presentations. And if I'm allowed to ask a technical question, as I typically do, I just want to know your opinion on the following point. Do you think there is some place for 3D augmented reality, like 3D neuronavigation, when you project a 3D model of vessels and nerves into the wound, so you visualize some invisible parts of the anatomy? Do you think that technology makes sense, or is this absolutely redundant? What's your opinion on that point?
Thank you very much. So at augmented reality or virtual reality, it's also interesting field. So in my opinion, I think one of the difficult point of this surgery is opening the keyhole. That sometimes it must be just behind the sigmoid sinus, but sometimes difficult. If such technology is available to identify the sigmoid sinus during the operation, I think that it's extremely helpful for me. That's my opinion. Thank you.
Thank you. So the approach, just for the approach. Thank you so much.
To the audiences, if you have any question, you may ask. Meanwhile, probably one question from me, Professor Komatsu. For the hemifacial spasm, do you have a EMG monitoring to tell your result, Professor? And how do we interpret?
Thank you. Yes. The monitoring for the facial nerve is also known, and some neurosurgeons use such a monitoring during the operation. But in my opinion, it's still not completely reliable. So that's why I believe the visualization under the endoscopy rather than monitoring. So we don't do the AMR during the operation.
Thank you, Professor. Biswas?
Hi, Konsu Sensei. Hope you are doing
Nice
great.
to meet you again. Yes.
Yeah. Sensei, just one or two questions. Number one question is, when we do not have the navigation or software like Amira for young neurosurgeon like us, where do you consider us to make the bar or the incision with
Uh,
respect to the anatomical relation, like the root of the mastoid or mastoid tip?
Thank you. That's also difficult for me to identify the signal science precisely. So I always analyze the CT scan
Okay.
meticulously before the operation. The shape of the mastoid process and also location of the emissary vein and sometimes the suture of the on the bone. That's I think the only reliable. So and the shape is different in each case, especially around this retrosigmoid area. So that's why it's difficult to simply say we should open here. So depend on the cases.
And one last question. Since if there is any bleeding, unwanted bleeding from the Dandy's vein, so you make a very small opening. How do you tackle that situation?
Thank you very much. That's also important for the endoscopic surgery. The venous bleeding, the bleeding from the dandy vein is venous bleeding. So that's why the hemostasis must be done only by the compression with hemostatic agent. So that's why that I make a surgical ball and put the surgical ball around the petrosal vein. That's the only thing. That's enough. And just wait and irrigate. The hemostasis can be achieved.
Oh, okay. Thank you. Thank you, Sensei. Thank you, Lu Sensei.
Thank you. Thank you very much.
Dr. D-Short, your question?
Yes, thank you, Professor, for great presentation. I have one question. Have you ever cases when you moved from endoscope to microscope due to the complexity of decompression, complexity of neurovascular conflict?
I'm sorry, I couldn't catch your
Were there
point
any cases when you moved from endoscope to microscope in order to finish operation properly because of complexity of neurovascular conflict? Or it's possible to make the compression in any cases with endoscope? Or there is some limitation of endoscope in case of complexity?
As long as I know, under my experience, I think the most of cases are manipulated by under the endoscope. But if the cistern is so small, in that case, even the endoscope, the operation is very difficult. But I think that's the same in microscopic surgery. But anyway, so my point is we use the instrument, and also we have to insert the endoscope in addition to instrument. So that's why the small space is very difficult to operate always. Is that answer for your question?
Thank you.
All right. So sorry.
Thank you, Dr. D-Short. Any comment from Professor Yokokato?
It's not comment because we work together. Maybe almost all case I joined his surgery. So I think Koma Sensei he emphasized about usefulness. The endoscope and microscope are almost equal. No, I don't think so. So endoscope is much has an advantage. Yes, because for example, the hemifacial spasm So when we do with the microscopes, it's quite difficult to identify the compression part. But with endoscope, so we can see very clearly that he showed us. So I think we need to expand the more endoscopic use for microvascular decompression surgery, I think, for a young generation, next generation. I think. That is not a comment, my opinion. Thank you very much.
Thank you, Professor. I think indeed we saw just now ICG with endoscope is quite clear because the light is nearer to the nerve. Let us hear the concluding remark from Professor 𝒔𝒐𝒊𝒂𝒂, Professor.
Yes, I completely agree with Professor Kakato on with the use of endoscopic technique, especially in the complex cases of offending vessel, especially with when you are suffering with reaching the most medial part of the brainstem and the root exit zone of the trigeminal or facial nerve. I think this is the most flexible and easy technique to reach the offending vessel and solve the problem. And yes, I completely agree with endoscopic technique, and for the coming generation, next generation, it would be a good option to acquire this knowledge. Thank you so much, Professor Komatsu, for this wonderful presentation.
Thank you. Thank you very much.
Thank you, Professor 𝒔𝒐𝒊𝒂𝒂 and Professor Komatsu. Let's move on to the next speaker, Dr. 𝒔𝒑𝒂𝒔𝒄𝒂𝒄. You may start your lecture.
So currently, my colleague 𝒔𝒑𝒂𝒔𝒄𝒂𝒄 is we're working in the same department, skull-based department. So we do skull-based and vascular cases. I mean, the vascular cases of especially the microvascular decompression. So 𝒔𝒑𝒂𝒂𝒔𝒄𝒂𝒄 is specialized for pain relieving techniques in trigeminal nerve, especially in trigeminal neuralgia, hemifacial spasm, and he's doing many other manipulations of trigeminal nerve, including radiofrequency ablation and many other. So please, 𝒔𝒑𝒂𝒂𝒄.
Thank you, Mr. 𝒔𝒑𝒂𝒂𝒄, for this great presentation of me. Good morning, dear colleagues. I am honored to make a presentation here today. My presentation related to our experience of handling a condition like trigeminal neuralgia and hemifacial spasm. Our center, it's a main center of neurosurgery in Uzbekistan, and we manage with all cases, with all neurosurgical cases, especially for trigeminal neuralgia. Especially for trigeminal neuralgia, in 1 year we have about 100 cases, and 70% of these cases go for MVD and 30% for radiofrequency denervation. But hemifacial spasm is too rare, about 50 cases in a year. And in 10 of these cases, we do MVD, and in 5, Botox. It's approximate numbers of our 1 year experience. Classical trigeminal neuralgia and hemifacial spasm are the neurovascular compression syndromes characterized by abnormal proximal activity of cranial nerves due to the chronic pulsatile compression of their roots. Both conditions result from focal demyelination and of the affected nerve, and most effectively treated by microvascular decompression surgery. First, I want to make some historical overview. This both condition first was described by Avicenna, mentioned the several cases of trigeminal neuralgia and hemifascial spasm in his book Canon of Medicine. And at that time, Avicenna suggested that this condition may be linked with nerve damage. And this illustration of Avicenna. Okay, only in 1821, Charles Bell attributed both the syndrome trigeminal neuralgia and hemifascial spasm to the trigeminal and fascial nerve. And after this time, we start treated this condition more properly. According to hemifascial, Joseph Babinski first called this condition hemifascial spasm in his patient. He also described a symptom named as a sign of Babinski, which is very helpful for differentiating hemifascial spasm from 𝒓𝒂𝒂𝒄𝒄. And Walter Dendy first introduced microvascular decompression, and Peter Janet improved and popularized this method by using microscope. This slide shows general characteristic of trigeminal nerve and hemifascial spasm, and I should note that this both condition classical trigeminal neuralgia and classical hemifascial spasm appear after 40 years old, and they both slight prevalent in women. Have slight prevalence in women. Now I want to talk about pathogenesis. Today we believe that neurovascular conflict is inborn, and chronic pulsatile compression not enough to cause trigeminal neuralgia or hemifascial spasm. The one factor still unknown in pathogenesis which trigger demyelinization and start vicious circle of this disease. And one of them, we think maybe herpes zoster, because in many cases with trigeminal neuralgia, we found the increasing amount of herpes zoster in their blood. And in some cases, antiviral drugs help to relieve patient. It may be the main reason of trigeminal neuralgia and other nerve damage. Okay. The main questions of Hamlet always actual. There is no consensus about doing or not to the MVD. And now I want to share with our tactic, our opinion, when we do MVD or when we choose other options. First of all, to determine the indication for surgery, we must determine the degree of contact with the vessel. In 2015 was published interesting work. The author analyzed the trigeminal nerve on both sides in patients with trigeminal neuralgia. They conclude the severe neurovascular conflict caused by arteria located in the root anterior zone caused classical trigeminal neuralgia. They said only compression and distortion may be indicate for operation. We think that even contact can cause trigeminal neuralgia, but they should be other factor which we should analyze. That's why we use traffic light principle regarding to degree of compression. In case of yellow, surgery should first analyze other factors, and maybe in case of contact, MVD help patient, not only compression, not only distortion. Some authors say that to determine the indication for surgery, we must determine the localization of contact. Others suggest that transitional zone and root enter zone is highly susceptible for neurovascular conflict. We agree with this, but also peripheral part conflict or contact in peripheral part also may lead to trigeminal neuralgia. We conclude that for development of demyelinization and symptoms of trigeminal neuralgia or hemifascial spasm in peripheral part should have more longer time for development this condition, and root enter zone is most vulnerable part. That's why in many patients, we have contact in this region. Saying in other words, peripheral part is more armored part of this nerve, but the great pressure or great power also can lead to neurovascular conflict, and root interzone is most vulnerable part. This interesting work shows that venous conflict mostly occur in peripheral zone. That's why we think that peripheral zone is also may lead to condition like trigeminal neuralgia and hemifacial spasm. It needs more time. That's different. And what about clinic? We know that we divide trigeminal pain in trigeminal pain first tape and second tape, and we believe that second tape, or saying in other words, atypical symptoms may occur because of conflict in peripheral part. Root interzone only developed classical symptoms like shock pain, and the conflict in peripheral part may lead to the atypical tape of trigeminal neuralgia. To determine the indication for surgery, we must determine the tape of vessel. Here's a list of vessels which can lead to conflict or contact, and knowing anatomy is essential for preparing surgery. Okay, the diagram from Rotten, it's a great diagram, shows how vessel can cause conflict, and during operation we come up with this tape of conflict. In this illustration, they include I think 90% of all conflicts, and also tape of vein. And in case of vein, we should note that we should know general configuration. Maybe for preparing for surgery, we should note main venous tape of conflict, because venous conflict is always difficult to manage. In some cases, we have to sacrifice some veins, and knowing the main variation help us to make some to sacrifice some small veins and save one vein in order to release the postoperative headache and other symptoms. Okay. Also, the place of contact of the vessels with the nerve may have correlate with damage or symptoms along the trigeminal nerve. Rostral compression of trigeminal nerve cause lower facial trigeminal neuralgia. Medial or lateral compression cause V2 pain, and compression of caudal side cause V1 trigeminal neuralgia. Knowing this is essential. Sometimes in case of contact, we compare symptom with place of contact. If if place of contact have similar symptoms, we recommend microvascular decompression, even in case of contact of vessel with nerve. And other factors which cause trigeminal neuralgia. Now I will show several cases which we come up during our experience. First is anatomical features in small posterior fossa. Small posterior fossa can lead to trigeminal neuralgia, mass lesion, and absence of Meckel case. This case of patient with third ventricle colloid cyst suffer from trigeminal nerve. After removing, here we show how colloid cyst narrows the posterior fossa and lead to compression of trigeminal nerve. After removing cyst, pain is relieved. Next case is the case of small posterior fossa volume. We see that here the small volume of posterior fossa, and this patient operated twice for MVD in other hospital, and in both cases trigeminal neuralgia do not release. That's why in this case, yeah, the reason of this small posterior fossa, here bone have go up, and displace and compress the cerebellum, brainstem, and trigeminal nerve here. In this case, we recommend doing dural and bone decompression of posterior fossa in order to release the pain. And the next interesting case, patient, male, she hasn't any Meckel caves. There was an absence of Meckel caves. He suffered from V1 branch neuralgia. In this case, we recommend her doing internal neurology or some blockade. She choose making blockade, alkalization of nerve. What's interesting in this case, we can perform radiofrequency demyelinization because of risk of damage of carotid artery in the case of absence Meckel caves. Now I want to show video cases. This interesting case, female, 75 years old. She has trigeminal neuralgia from both sides and also hemifacial spasm with trigeminal neuralgia in the left side. Yeah, left facial nerve and 𝒂, which make conflict. And both trigeminal nerves also has conflict with superior cerebellar artery. In this case, first we decompress the trigeminal nerve. Yeah, we can see both branches, rostral and caudal branches of trigeminal neuralgia cause damage of trigeminal nerve. After making interposition, we put Teflon pad. Yeah. And here also some small branch we also in this in place between this small branch artery also put Teflon. Yeah, and make total decompression, and then turn to decompress the facial nerve. Facial nerve has a complex conflict with several branches of 𝒂, as you see here. It has loop, it has several branches, and all of them has stick contact with facial nerve. And it was one of the difficult operations. We operate this patient nearly 9 hours in order to make proper decompression of nerve and save the vessels. And also here it was contact with glossopharyngeal nerves. This conflict will also relieve also the glossopharyngeal nerve from conflict with vessel. And then put the Teflon pad between facial nerve and vessel. This is the final result. And we think that it was a difficult part, but we operate this patient after several times. Second part, second trigeminal neuralgia side, and we come up with more stiff, more thick conflict. I will show you the same patient. We operate trigeminal neuralgia in the left side. As you see, he has a stick formation between vessel, arachnoid, and trigeminal nerve. Even with scissors, we hardly able to cut this thick membrane. And after clearing the membrane, we see that arteria make loop in this place and hardly stick with nerve. Yeah. We able to divide artery and nerve only with scissors. It's superior cerebral artery, and we see that this place divide into branches, rostral and caudal. First, we put hemostatic agents in order to make hemostasis in this region, and then we replace hemostatic agents with Teflon pad. And patient safe from all pains and hemifascial spasm in this case. Okay. Regarding hemifascial spasm, I want to talk about delayed results. Delayed results, it's the most complicated part of this disease, and we try to always make botulotoxin before discharging. Nearly the 30% of our cases with hemifascial spasm have delayed results. After operation, they still have hemifascial spasm. And that's why we always do botulotoxin injection in this case, and they go home without any hemifascial spasm. And it's a very good tactic for overcoming these cases. We also have delayed cases who write us after 6 months maybe and write, "Thank you, doctor, I released from hemifascial spasm," who go without botulotoxin. And we should always talk with patient about this condition that may be delayed result, but in order to relieve from this condition, we should do operation and botulotoxin, and then we can get our results. Okay. In conclusion, I want to say that in order to make decision about doing MVD or not to do MVD, we should carefully analyze all aspect, all clinic, also MRI image of patient, and then start doing surgical procedure. And this is the main. And only this way can lead to good results in any cases, and we can reach more than 99 cases of good results from MVD without any pain and tics after surgery. And I want to finish my presentation with words of George Orwell: "In the face of pain, there is no heroes," and patient always suffer from this pain, and neurosurgeon should be the hero who save patient from this pain, and we should be careful with every patient, and we should relieve from this suffer without harming this patient. Thank you for your attention.
Thank you, Dr. Dishot, for your presentation. I pass the session to Professor Yoko Kato for her comment. Professor.
Thanks so much. So maybe I think under the microscope, sometimes we cannot see clearly And maybe because your result is very high percentage, and a good result is very high percentage. Maybe I think it's okay. I think sometimes you should try the transposition. That is, I think maybe for long result, I think it's much better result you can obtain. I think. But anyway, congratulations. Wonderful talk. Thanks so much.
We also planning doing transposition, but the narrow space is our limitation. I think we first, in order to start, we should choose the case with wide peduncular system and then start, because starting with good result is essential in surgery. When first, if first case go good, you have motivation to do another.
Yes, you're right. Yes. Thank you so much. But anyway, I enjoyed also so many painting, and that was nice. Thanks so much.
Thank you. Thank you.
Thank you, Professor Yoko Kato. Professor Gleb Deninov, your comment?
Thank you. Thank you so much, Professor Hajimeta, for a very detailed historical review and really deep dive into the problem of microcompression syndromes. I have two questions. Are you conducting your own research on the topic of microvascular decompression? And if so, which ones? And the second question is, what are the most difficult problems in the diagnosis and treatment of microvascular conflicts that you encounter in your practice? Thank you so much.
Professor, thank you. First question, can you again?
Yes. Do you carry out your own research on microvascular decompression? Do you have any scientific projects? And if you do, what do you study?
Thank you for your question. Yes, we do our research, but the research is local. In our country, we have several steps of getting some degree, and we planning finish our research for making academic degree. We call dissertation this work, and yes, we do. And our main topic is doing MVD, and also we learn the influence of internal neurology. In some cases, we have to do internal neurology in case without vessel compression. It's very interesting cases, and we have to make some treatment for this patient which have long lost results, because radio frequency the innervation may have relapse, pain may have relapsed after 3 years. And in case of internal neurology, we see that patient have more longer pain-free period. And our research dedicated to analyze microvascular decompression and internal neurology in patients with facial pain. Also, we use botulinum injection in case of trigeminal neuralgia, in case of idiopathic trigeminal neuralgia with some demyelinization, or in case of post-ischemic pain syndrome. In these cases, botulinum toxin very helpful, where even MVD and internal neurology don't work. We don't know the pathogenesis, but botulinum toxin injection in the trigger point, it's very helpful in cases where we can do anything. And our research dedicated to this nowadays. And your second question, most difficult in case of MVD and trigeminal neuralgia surgery. I think cases which we always fear, it's basilar artery ectasis. And in some cases, we enable to move these vessels. And in these cases, always we do internal neurolysis after putting Teflon pad, because even interposition in some cases impossible. We cannot interpose this vessel and nerve in case of 𝒂𝒂 in narrow space of posterior fossa. This is a difficult case, and in these cases we always do interposition and always do internal neurolysis of trigeminal nerve in order to have relieve the patient pain. I think that's all. And all cases of hemifacial spasm always complicated. Even we use ECG, we cannot be 100% sure we relieve patient from compression or no.
Yeah, thank you so much. Very interesting. Thank you.
Thank you, Professor Gleb. Probably one question from me, Dr. 𝒔𝒑𝒐𝒏. In how many patients, or in terms of percentage, patients who do not show obvious neurovascular conflict, but still having a trigeminal neuralgia and cannot be treated in other means, what is the percentage that you would offer a surgery, Dr. 𝒔𝒑𝒐𝒏? Thank you.
It's up to patient. We always our first choice is surgery, internal neurolysis, and our second choice is radiofrequency ablation. And patient choose which method of treatment we should do. Sometimes patient fear of pain during radiofrequency, and they choose internal neurolysis. I think in most cases, patient choose always radiofrequency. 80% go to radiofrequency, and only 20% go to internal neurolysis in cases without contact or conflict.
Thank you. Probably we would ask any question from you, Professor Komatsu.
Thank you. Thank you for your presentation. You mentioned trigeminal neuralgia due to venous system, the venous system. So, but in my opinion, it's very difficult to distinguish with idiopathic trigeminal neuralgia and trigeminal neuralgia due to venous system. In my opinion, most of the cases are idiopathic trigeminal neuralgia. It's not the trigeminal neuralgia due to venous system. How do you diagnose? How do you recognize them? If you have any opinion, please teach us.
Thank you for your question, Professor. Interesting question. First of all, in the case of venous conflict, we look to a clinic. In most cases, they have not atypical trigeminal neuralgia with a dull pain and without any pain, shock-like pain. This first indication for doing MVD, atypical pain with venous conflict. Second, we look MRI and localization of conflict. If localization of conflict similar with roots of trigeminal nerve, first, second, and third, and then we decide to do surgery. And even in MRI, it's difficult to define venous conflict when we have, and veins in most cases go near to trigeminal nerve and we have to look more detailed MRI in order to distinguish whether it's vein or whether it's artery. And in most of cases, they combined with arterial conflict, and we look in these cases we look in patient clinic. If clinic say that this conflict may lead to this clinic, we do surgery. And also in our department, our neurophysiologists do ECG for before operation for sensitive nerves. They also can say us it's this condition because of conflict or because of some other condition, and we also look for ECG result. And after it, we decide doing surgery, doing MVD, or doing another surgery. It's always complex and individual. I think in each cases we should go deeply to patient clinic and the patient image in order to be sure that we choose correct way for treatment. I think not all venous conflict idiopathic. Yes, maybe some cases have idiopathic neurology, but venous conflict also may cause trigeminal neuralgia. We think from our experience.
Okay, thank you very much.
Thank you to our both speaker, Professor Komatsu and Professor Kojimeto. And we come to the end of
sorry.
Yeah,
At the
sure.
same time, I have a question for Professor Komatsu. I had several weeks ago a discussion with one of the professors of Weill Cornell Medical Institute in US, and they say they strongly believe that in every case of microvascular decompression, they used to cut or coagulate one of the branches of superior petrosal vein in order to it's like a prophylactic measure, prophylactic procedure to prevent further pain that can be caused by vein. So they decided to coagulate or cut one of the branches of superior petrosal vein in every case. So this is their decision. Of course, many of us was not agree with this, but I don't know. Is there any justification? What do you think?
So as I said, my opinion is the trigeminal neuralgia due to venous system is very limited. Probably most of the cases, I think the veins are not related to the pain. So that's why we should leave them. We should not manipulate the venous system. So I think that these are most of the cases are idiopathic trigeminal neuralgia. Just give the internal neurolysis. I think it's the best treatment. It's my opinion.
Okay, thank you.
So just a little shot, Mamadari. Thank you very much for your comment. But what is a mechanism? Because the US team, they coagulate all the petrosal vein. That is one of the way, I think. But what is a mechanism of the venous compression to make some trigeminal neuralgia or hemiplegia spasm or whatever?
I was also surprised because they think that any vein that is lying on the surface of the trigeminal nerve may cause some pain, and they are coming with this perspective, and they want to just take away any compressing factor, and including that vein. So they justify their opinion with this answer. I don't know. Yeah.
Because the vein is no pulsation and also just one layer. Maybe you can suggest them, US team, to do the neurolysis, please.
Yes.
You can teach them, please.
Yes. Sure.
Thank you. Thank you. So we come to the end of today's webinar. Since there's no further question from our audiences, I would like to thank both speakers, Professor Komatsu and Professor 𝒂𝒌 for excellent presentation. Before we end, probably we hear a small concluding remark from both our chair, Professor 𝒔𝒑𝒆 and Professor Yogato. Professor 𝒔𝒑𝒆.
Thank you so much for joining this webinar series. It was an honor for us to participate in this webinar and share our humble experience. And I want to say that microvascular decompression is a beautiful surgery that is, when you achieve a good result, patient is extremely happy. Patients has gained a new life. And we all neurosurgeons have to acquire this technique, both microscopically or endoscopically. The end result should be decompression and patient's pain relief. And some cases may be very challenging, like a complex vessel conflict in the case of double vascular compression. But still, it's vascular surgery, and we have to acquire the technique of decompression very good. And thank you so much for teaching us, both two speakers, Professor Komatsu and Professor 𝒔𝒑𝒆, and for our mentors. I'm grateful for organizing this conference webinar. Thank you.
Okay, thanks so much. So already Dr. 𝒔𝒑𝒆 said everything, but I think it's a time for the minimally invasive era. So I think even still the developing country, I think maybe you should start. Maybe 𝒔𝒑𝒆 Mamadali, maybe you are the role to teach them. And the most important thing is to see clearly the point. Otherwise, I think we cannot do the conclusion, good results in the session. I think. So that is my conclusion. Thank you very much for both excellent talk. Thank you so much.
Thank you, everyone. So it's a time for us to say bye-bye. But for your information, we do have another collaborative webinar next week on endovascular surgery. Hope all of you can join us again. So this is end of the seminar for today. It's bye-bye from all of us. Thank you, Professor. Thank you to all the audiences.
Thank you.
Thank you so much.
Okay.
Daniel, thank you very much.
Thanks so much. Bye-bye.
Both �𝒔𝒆, thanks so much.
ありがとうございます。
先生、ありがとうございました。